Good afternoon, everyone. Thank you for joining us today for our presentation specifically for payers. I'm Adam Rossi from the Communication and Outreach Unit at the Workers' Compensation Board. And today we'll share the latest updates on several initiatives that are helping to make the board better for payers and better for the workers' compensation system overall. On hand to assist with your questions today, we have James Wessel and Barbie Badischer from our Office of Operations and Programs, Dr. James Tachi, the board's medical director, along with Audrey Cunningham, Paula Rauch, Christopher Failing, and Eileen Moss from our medical director's office. We will be using the chat feature to receive your questions today. You can enter your questions in the chat box at any time. If you look on the bottom right side of your screen, there is a little chat bubble. Just open that up and you can enter your questions at any point. I do see we have a few questions in here already. I mentioned briefly a few minutes ago, I will reiterate, we are going to hold off on answering any questions until the end of the presentation. But again, if you have a question at any point today, feel free to pop it in that chat box right there. We will answer as many of your questions as we can. But if you have questions that we don't get to today, or if you think of something after the session ends, we will be providing you with resources at the end of the presentation. Also, your name and email address were captured when you signed in here today. However, if there's something you'd like us discuss with you further, a topic that maybe we either haven't mentioned today, or if we talk about something and you want more details on it, feel free to leave your name and email or a contact number for you, and we will do our best to get back to you. Again, we do have your email, so that shouldn't be a problem. But if there's anything you want to talk about, feel free to leave us your contact email or a contact number and email and your name, and we can get back to you at some point. And again, the chat settings are set so that only panelists on this call will see your questions or comments. So there's no need to worry about other people seeing your personal information. All right, so with that, we're going to go ahead and get started. So we recognize that there's been a lot of activity and communications from the board on various initiatives. So we wanted to remind you of some of our latest initiatives and provide you with a few new updates. We will start today with some brand new updates on Onboard, and we will follow with a review of the board's recent permanent telehealth regulations. We will then review the recent updates to disability regulations, followed by some reminders regarding the CMS 1500 form. We will also review important information about workers' compensation as it pertains to COVID-19. Finally, we would like to remind you of some helpful tips for efficiency when filing board forms, and we will review some additional resources available to you. We will, again, leave time at the end of the presentation for any questions. We're going to start with some exciting updates from Onboard that officially went into effect last night. You should have received an email update on this if you are subscribed to our emails. First, the option body part condition not accepted or established was added under the reason for granting without prejudice dropdown when responding at a level 1 review. Previously in Onboard, payers at a level 1 review did not have the option to grant without prejudice on the basis of a body part condition not accepted or established. There have also been several updates to the level 2 review process, including the removal of level 1 reviewer title options, more title options which may request additional information in a new attestation. In a level 2 review, the level 1 reviewer titles will no longer be an option when selecting the title of the reviewer. In the title dropdown, Other will no longer be an option. The new option of Per the attached specific level 2 review will be available. If the Per attached specific level 2 review is selected, 2 additional fields will populate with the MPI number and physician name. If an MPI number and/or physician name is not validated, payers will manually enter this information. A new attestation for level 2 reviewers will read, by submission of this response to a prior authorization request, I certify that the level 2 determination was conducted specifically by a carrier's physician as per the attached documentation and in accordance with the workers' compensation laws and regulations. Where duration is entered for a durable medical equipment prior authorization request, weeks have been added to the DME duration weeks field labels to make sure the information entered is accurate and clear. This field label update is available during the creation of a DME PAR, where applicable, and is also included in the system-generated document. When an onboard user attempts to access onboard with an unsupported browser, as defined in these system requirements, an updated display message now appears for users. This message provides the list of supported browsers and directs users to the system requirements page. This update ensures that new users do not experience issues if they don't meet the onboard system requirements. Lastly, we recently updated the trainings webpage. These resources are highly beneficial, providing you with further information on the updates and a walkthrough of the new functionalities. You can review these updates at wcb.ny.gov/onboard under the Trainings tab in the Payer section. So, on that note, I'd like to take a minute to review how Onboard is going. As you know, Onboard Limited Release, the first phase of our system, was implemented in phases from March 7th of 2022 through May 2nd of 2022, beginning with the submission of PARs for medication, which are known in the system as medication PARs. Today, providers and payers are using Onboard to request and review prior authorization for medication, durable medical equipment, and treatment or testing, and we have hundreds of these PARs successfully flowing through the system each day. To date, nearly 49,000 payers and reviewers have signed up for access. Since Onboard launched, more than 1 million PARs have been filed online. 100% of medication, behavioral health, and DME PARs are resolved within 3 days, and most other PARs are resolved within approximately 30 days. Approximately 95% of these are resolved at the level 1 or level 2 stages of review, meaning they are responded to without escalation. Over the course of the year, Onboard has made more than 45 system enhancements in direct response to feedback from healthcare providers and other users. As a reminder, payers will need to log into the medical portal to access Onboard. Every user will need their own login credentials. A single login cannot be provided to an organization to be used by all users who are part of that organization. There is no limit to the number of users an organization can have. Claim administrator access for insurers, self-insured employers, or third-party administrators is granted using organizational profiles based on eClaims trading partner information. The payer is ultimately responsible for the review of PARs. A payer may designate a medical review organization to review their PARs. However, the medical review organization must first complete the online medical review organization medical portal registration. Pharmacy benefit managers, known as PBMs, may be designated by the payer to review level 1 medication PARs. The PBM must complete the online PBM medical portal registration process prior to a payer designating them as the reviewer. Once a PAR is submitted, you, the payer, have a set number of days to respond. Response requirements vary for certain PAR types. Responses for MTG confirmation are required within 8 business days, and responses are not optional. MTG variants and MTG special services responses are required within 15 calendar days, but the response time is extended to 30 days if an IME is requested. Non-MTG over $1,000 responses are required within 30 calendar days. Non-MTG under or equal to $1,000 responses are required within 8 business days, and medication and durable medical equipment responses are due within 4 calendar days. These timeframes may vary based on weekends or holidays, depending on when the PAR is submitted. Please note, if the wrong PAR type is submitted by the provider, it is appropriate to deny the PAR and mention why in the comments section. So, for example, a confirmation PAR was submitted when a special services PAR was required. If the provider wants the service, they should resubmit as a special services PAR. You can also review this chart on the payer overview page at wcb.ny.gov/PARs. nya.ny.gov/onboard. So rather than release onboard all at once as a large-scale initiative, the board does plan to develop the onboard system improvements as a series of smaller, discrete projects that will be released incrementally. The system upgrades will use web-based platforms and electronic data, increasing our ability to enhance these systems over time. We expect that this approach will enable the board to be more responsive to stakeholder feedback over the course of this multi-year program. Currently, the board is advancing the onboard program by focusing on two key areas. The first area of focus is the board's expansion of the use of eForms and the development of APIs to streamline data submission. The paper versions of the Request for Further Action, which is Form RFA-1LC, and Request for Assistance by an Injured Worker, which is Form RFA/1W, are transitioning to an eForm with an intelligent online submission and routing process, although the paper-based process will still be available for injured workers who need it. The new process will be wizard-based, meaning it will walk users through fillable fields of a new eForm. The wizard will provide numerous fields for attorneys to enter pertinent information, allowing for quicker, more efficient board processing and response. Additionally, attorneys will also have the option to submit Form RFA-1LC via an application programming interface known as an API. APIs enable independent computer systems, so for example, stakeholder systems and the boards, to talk to one another and exchange data, automating processes and reducing the need for stakeholders to manually enter data into web-based eForms. When used correctly, APIs will be transformational in terms of providing faster, more efficient workflows compared to current paper-based form processes. The schedule for these efforts is in development, and the board is committed to keeping stakeholders informed as our planning efforts progress and a timeline is available. The second area of focus involves the collaboration of various board divisions to formalize future processes and requirements for the new onboard system in addition to engaging our external stakeholder community. Understanding all processes and requirements will help us design and build a more intuitive, user-friendly system that benefits all board stakeholders. We are excited about these onboard initiatives and look forward to sharing updates on our progress in the coming months. We are going to remind you of some telehealth regulations that were recently put in place. Telehealth is now a permanent part of the workers' compensation system, following the adoption of a regulation that was many months in the making, with several iterations and rounds of public comments. We're very happy to now have this in place, but I will briefly share how we got here and what it means. In New York State, telemedicine was an option before COVID-19, but it was limited to phone calls to discuss the test results in lieu of an in-person visit, and within a finite time window. During the pandemic, emergency telehealth regulations significantly increased the permissible uses of telehealth on a temporary basis to ensure continuity and access to care. Emergency regulations were extended multiple times. A 2021 study by the Workers' Compensation Research Institute found that telemedicine is changing the way healthcare is delivered on a national level. As of the first quarter of 2021, use of telemedicine for evaluation and management, known as E&M services, was still higher than prior to the pandemic. However, post-pandemic, physical medicine visits have returned to near pre-pandemic levels. Costs for services that were delivered both via telemedicine and in person were generally similar. The number of visits per patient when telemedicine was present, relative to only in-person care, was larger when follow-up visits were a mix of telemedicine and in-person services, and smaller when all follow-up visits were delivered exclusively via telemedicine. The board's permanent telehealth regulations have gone through several iterations with extensive stakeholder input, and the new permanent telehealth regulations took effect July 11th of 2023, following the expiration of the last set of emergency regulations. Now let's dive in on some of the details surrounding this new permanent telehealth regulation. The newly enacted New York State regulation states that telehealth appointments may be performed by physicians, podiatrists, psychologists, nurse practitioners, physician assistants, and licensed clinical social workers through two-way audiovisual or audio-only communications. The provider must also be available for an in-person visit within a reasonable travel time if necessary. An in-person visit may be required, as may be specified in the medical treatment guidelines, or based on the clinical age or stage of the condition as follows. For MDs, DOs, DPMs, NPs, and PAs, it would be the initial visit. Every third visit, whether acute or subacute. Every 3 months, if chronic but not at MMI. And annually, if chronic and at MMI. For psychologists and licensed clinical social workers, telehealth should be permitted for the first and subsequent visits, including group therapy, irrespective of clinical stage of the condition. Remote behavioral health visits should be limited to situations when there is no benefit to in-person services versus remote services, or when an in-person office visit poses an undue risk or hardship on the patient. The reason for the use of a remote telehealth visit should be documented with each use of a telehealth visit. Treatment may not be rendered via telehealth for chiropractors, acupuncturists, physical therapists, or occupational therapists. Telehealth appointments that have been scheduled prior to the effective date of this new permanent regulation do not need to be changed to an in-person visit in order to conform to this regulation, and the use of telehealth should not be the sole basis for challenging the results of such visits. However, any appointments scheduled after July 11th of 2023, which was the effective date, must conform with this regulation. The regulations also delineate various clinical scenarios that indicate an in-person exam may not be necessary, such as routine follow-up appointments after a comprehensive initial in-person exam has already been conducted, or to discuss test results and/or counsel on clinical options, and when an in-person exam is necessary, such as to perform procedures, emergencies, eye conditions, nuanced or complex issues, etc., or when an in-person physical exam might reasonably impact the accuracy, quality, or certainty of the assessment, treatment, or recommendations. Some scenarios do require an in-person visit. They include, but are not necessarily limited to, urine drug testing, appointments to determine permanency, impairment, or disability, initiation of a chronic medication, or if the patient lacks the technology, capacity, or the desire for telehealth visits. We are frequently asked whether independent medical exams, or IMEs, can be performed via telehealth. It should first be noted that technically IMEs are not considered treatment. With respect to performing IMEs remotely or virtually, this is permissible if all of the parties agree, and as long as the IME is not being performed to determine permanency or permanent impairment. As I mentioned earlier, these regulations went through several iterations incorporating extensive stakeholder input, and we do believe that the newly enacted regulation strikes an excellent balance of that input. Since implementing the permanent telehealth regulations, the board has received inquiries regarding the proper method for payers to object to treatment via telehealth in instances where the payer believes the use of telehealth was inappropriate and inconsistent with the regulations. When a payer believes that treatment by a physician, nurse practitioner, physician assistant, or podiatrist via telehealth has been provided improperly pursuant to 12 NYCRR 325-1.26B1, the fact that medical treatment was provided via telehealth should not be the sole basis for a legal objection to a bill for such treatment, and the services should be reimbursed unless they are such that telehealth is clearly precluded by the regulation. For example, an initial visit with a provider or visits to determine permanent impairment. In other more nuanced instances where the payer believes that medical services for a physical injury or illness are being improperly rendered via telehealth, the services should be reimbursed, but the payer may request that future similar services be conducted in person by filing a request for further action by the insurer or employer, which is Form RFA-2. The payer should check box K and request a direction for a future in-person visit in accordance with the regulation, and state why the visit should not be performed via telehealth. If a board ordered to conduct a specific clinical service in person instead of via telehealth is ignored or otherwise disregarded by the provider may be subject to administrative action. The payer should not file a notice of objection to a payment of a bill for treatment provided, which is Form C8.1B. Filing of Form C8.1B in these instances will be found moot. Treatment rendered by chiropractors, acupuncturists, physical therapists, and occupational therapists under the New York Workers' Compensation System may not be rendered via telehealth. When a payer believes that treatment has been improperly provided via telehealth by one of these provider types pursuant to 12 NYCRR 325-1.263 B3, the payer may file Form C8.1B with the other box checked and noting in the description that the provider type is not permitted to perform medical treatment via telehealth. We now want to remind you of updates regarding disability regulations, which were adopted in April of this year. In keeping with the goal to make it easy for workers to receive compensation they are entitled to, the chair adopted amendments to sections 355.4, 363.1, 363.11, 363.13, and additions of sections 363.15 and 363.16 of Title 12 in NYCRR to update and clarify the disability benefits regulations and disability benefits claims process, conform the regulations to the statute, and align several sections with paid family leave. The notice of proposed rulemaking was published in the October 12, 2022 edition of the State Register. The notice of adoption was published in the May 10th, 2023 edition of the State Register, and these changes will take effect on January 1st, 2024. The board is currently in the process of updating the disability forms, creating new forms where appropriate, and updating the board's website. And these updated forms will be available soon. To read more about these updates, you can visit the website at wcb.ny.gov and select the regulations link on the bottom left of the homepage. You can find the link at the top of the adopted regulations section on the next page. So as the board continues modernizing and improving stakeholder interaction with our systems, we now look back on our official transition to the CMS 1500 form, the Universal Medical Billing Form, more than 1 year ago. Since July 1st of 2022, more than 6 million CMS 1500 forms have been submitted, including 1.4 million electronic submissions through an XML submission partner. More than 10,000 providers have submitted their CMS 1500 forms electronically through an XML submission partner. We strongly encourage our providers to sign up for XML submission if they have not already. So as mentioned, the board transitioned to the CMS 1500 a year ago to reduce the administrative burden on participating providers who previously had to use separate board-specific forms for their workers' comp patients. Since then, healthcare providers have been required to use the CMS 1500 for all workers' comp medical billing. Electronic submission through an XML submission partner is strongly encouraged, as I mentioned, although it is not currently required. As part of the initiative, use of prior medical billing reports, including the doctor's initial report, which is Form C4, and the doctor's progress report, Form C4.2, have been discontinued. Payers are required to use the new C8.1B and C8.4 with applicable claims adjustment reason codes, or CARCs, to object to medical bills. Workers' compensation payers will electronically transmit the EOBs or EORs to their XML submission partner upon adjudication of the associated electronic CMS 1500 medical bills. We do want to note that provider types who are not permitted to opine on causal relationship or a level of impairment are not required to submit this information. The board has developed a medical narrative report template that can be used to create the medical narrative report that accompanies provider submissions of the CMS 1500 form. Providers should use this report when submitting the CMS 1500 form. The board strongly encourages providers to include 3 elements: causal relationship, work status, and temporary impairment in every clinical note, because that information is so frequently essential to the seamless administration of claims. There are several instances, however, in which this information is not as critical to the payer or the board, and it is not needed to properly adjudicate the medical bill. One example is a claim in which the injured worker has reached maximum medical improvement and permanent partial disability classification has been made. Moreover, certain provider types are not permitted to give formal opinions on causal relationship or degree of impairment. For full details, you can see the WCB authorized providers who can do what chart, which is on the board's website. In a communication from November of 2022, payers were notified that they should not routinely file Form C8.1B to deny payment to healthcare providers solely based on the absence of one or more of these 3 elements. Such legal objections may be resolved in favor of healthcare providers if this is the sole basis for the dispute, and the information is deemed by the board to be present, clearly implied, or not critical to the administration of the claim at the time of the clinical visit. If the payer objects to a bill, the legal objection that was filed must be resolved first. If the bill is still not paid after it has been resolved in their favor, providers can file Form HP 1.0. Please note the CMS 1500 does not change anything related to a payer's assessment of causal relationship. It merely informs providers that causal relationship is to be reported prominently in the medical narrative. A PDF of the report, as well as a chart listing medical narrative report requirements by provider type, can be found at wcb.ny.gov/CMS-1500/requirements under the medical narrative requirements section. We urge you to share this template with providers if you notice it's not being used. More information can be found on wcb.ny.gov/CMS-1500, or you can also email cms1500@wcb.ny.gov with any questions. As you may already be aware, workers who believe they contracted COVID-19 in the workplace may be eligible for workers' compensation benefits. As payers in workers' compensation, you provide crucial benefits to both employees and employers. The employee receives the lost time and medical benefits stemming from a compensable claim, and the employer has the peace of mind knowing its insurance coverage will ensure that employees are covered. We strongly encourage you to be proactive in distributing information about how to file a COVID-19 claim. Employees should be encouraged to file a claim if they feel they contracted COVID-19 at work. You should also encourage employers to help employees file claims and remind them it is illegal to take any disciplinary or discriminatory action against employees who file or wish to file a claim. Please review all claims carefully and timely, even if a medical report has not been received. More information on COVID-19 and workers' compensation can be found on our special COVID-19 section of the website, which is wcb.ny.gov/COVID-19. So the last thing we'd like to cover today before we get to your questions are some tips for you to ensure efficiency when receiving or filing forms and requests. We will start with forms C8.1b and C8.4. So, as previously mentioned, effective July 1st of 2022, payers are required to use the updated Form C8.1b and Form C8.4 to notify the Board of Legal and Valuation objections. Payers must use the same CARC and RAR codes on the EOBs and EORs sent to the providers. There are 4 scenarios when you should not be filing Form C8.1b or Form C8.4. First is when the amount billed for a CPT code exceeds the amount designated by the applicable medical fee schedule, and the payer pays the bill at the medical fee schedule amount. The other is when the payer reduces the amount of the bill to 12, 15, or 18 relative value units for evaluation services and modalities as set forth in the applicable medical fee schedule. When the payer reduces the amount of the bill pursuant to a contractual agreement with the provider, for example, a network or a PPO discount, or when there is a duplicate bill. The reason for payment reduction or non-payment, if there is a duplicate bill, should be set forth on the EOB. Next, let's review some tips for when filing Form RFA-1LC, Form RFA-1W, or Form RFA-2. To start, when filing any of these forms, please do your best to select the checkboxes provided rather than using the other field. This can lead to problems such as examiner delays or mistakes as the examiner is interpreting the request. Board has specific procedures for checkbox items, but not for the other field. In certain instances, the examiner could send a claim down the wrong procedural path, which can delay a hearing. Also, selecting other prevents the board from capturing data for reporting purposes. Also, please provide supporting documentation. This significantly decreases the workload for an examiner when reviewing RFA forms. Any relevant documentation not included or not found could result in the examiner sending back the request. When responding to PARs, we have a few tips to enhance your experience here as well. Payers should only use the Level 1 administration denial disallowed when the condition or body part has been formally disallowed by the board. Payers should respond to PARs in a timely manner to avoid receiving an order of the chair or a notice of resolution from the medical director's office. Failure by the carrier to respond timely to PARs will result in a waiver of the carrier's right to challenge the PAR based on medical necessity. We have an important update here, as we previously noted, with the new enhancement to onboard, through which the option body part or condition not accepted or established was added under the reason for granting without prejudice dropdown when responding at a Level 1 review. Previously in onboard, payers at a Level 1 review did not have the option to grant without prejudice on the basis of body part or condition not accepted or established. More information can be found on the payer section at wcb.ny.gov/onboard. Finally, the board would like to remind claim administrators to ensure timely filings of the first report of injuries, known as FROIs, and to properly notify the board of the correct claim administrator. This will avoid untimely filing penalties assessed by the board's monitoring unit. This also helps provide accurate information to onboard, ensuring PARs are given to the correct administrator. So as we continue to work on implementing improvements for payers, we are committed to increased communication with payers, such as this webinar and targeted emails. The board also has a special webpage for payers. You can visit the board's website at wcb.ny.gov and select the payers link at the top of the page. We will be expanding the content on this page by creating a What Payers Need to Know briefing page that highlights key activities, much like we've done today. We also plan to continue engagement with all of our stakeholders, including payers, as the board continues its modernization efforts via the future expansion of Onboard. For more information on Onboard, you can visit wcb.ny.gov/onboard. Resources include a walkthrough of the registration process, video tutorials, and recorded presentations for payers. More information on CMS 1500 can be found at wcb.ny.gov/CMS-1500. We also have a dedicated mailbox to answer any of your questions. Please note that is CMS 1500, all one word, no dash, at wcb.ny.gov. If you have payer-specific questions, you can call the helpline at 877-632-4996. You can also visit our website and select the payers link at the top of the homepage. For claim inquiries, you can visit wcb.ny.gov/contact claims, and you can submit your questions to claims operations. You can stay informed by subscribing to Get Board notifications straight to your inbox by visiting our website and selecting Get WCB notifications on the bottom of the homepage. You choose the topics that you'd like to subscribe to. You can also follow the board on X, which was formerly known as Twitter, Facebook, Instagram, and YouTube for board news, project updates, trainings, and more. So thank you again for attending this presentation on important updates for payers. We will now take the rest of the time to answer any questions you may have. Again, feel free to enter any questions you have in the chat box. But for now, I'm going to let our subject matter experts take a look at the questions that have already come in, and we will be back with you shortly. Thank you.
Hi, everybody. This is Paula Rausch. I'm a nurse in the medical director's office. We have a question. Can a claims adjuster override a level 2 PAR denial and grant the request based on an IME report that was not available for the level 2 physician to review when making their determination? The adjuster, only the reviewer who made the decision is able to override their own decision. If you, there is the ability within the system to grant after an initial denial, which the information for how to do that is right on our website. If you have any additional questions, please email our mdo@wcb.ny.gov and we'll be happy to assist you with that. There's also kind of hand in hand with that, another way for a claims adjuster to override or approve a PAR that has been denied at level 2. There is not. The level 2 reviewer supersedes the level 1 reviewer. And again, the only way to override a previous denial would be to grant after the initial denial at the level where it was denied.
Hi, this is Audrey Cunningham from the medical director's office. I had a question regarding the enhancement from last night. This was the enhancement that Adam referred to regarding grant without prejudice for a body part not established. So I understand that one or two of you might have been having an issue with that. This has been escalated to our OBLR and our technical team. You know, we will keep you posted, but we have escalated it. Again, we just put this in place last night, so we will get to the bottom of any issues you may be having. In addition, there was a question regarding the reimbursement enhancement for particular providers, the modifiers 1D and 1B for certain provider types. And that modifier is you are able to use that, or providers are able to use that request reimbursement with telehealth. Sorry, I can't speak today. So yes, the answer is yes, 1D and 1B can be used if the visits were via telehealth.
Hi, this is Paula again. There's a question on whether or not the workload admin can upload additional documents for granting without prejudice. The workload admin is not able to upload additional documents if they are functioning in the capacity as assigning the work request to a level 1 reviewer. If the workload admin is the one who is actually reviewing and going to put in the determination, at that time they would be able to upload documents. So it's up to whoever is the actual reviewer and who is actually responding within the system to upload those documents.
This is Dr. Tachi. There were several questions related to the new functionality with respect to L2 reviews. Just to be clear, the requirement has always been and still is that the L2 reviewer be a licensed physician, MD or DO. Pardon me. That licensed physician does not need to be New York State Workers' Comp Board authorized, but the physician does have to be licensed either in New York State or the state where the physician practices. The new functionality does indeed allow administrative personnel to upload an opinion that has been given, an L2 opinion that has been given, say, saved as a PDF, etc., pardon me, by the L2 physician reviewer. But it doesn't change the fact that the L2 review, again, has to take place and be performed by a physician reviewer. When the opinion is up, the L2 reviewer physician's NPI number has to be included. So that's the change in functionality. It makes it easier, say, perhaps for L2 reviewing physicians who are not as tech savvy or have difficulty with the onboard platform to have their administrative personnel upload their opinion, but it still has to be the physician and their opinion, a licensed physician in their opinion that is the L2 review, and their NPI has to be included.
Hi, this is Audrey. There's a question with respect to the telehealth regulations. I will add a link to the regulation. It's section 325-1.26. So again, I'll add a link at the end of this. And also there was a question with respect to notifications. If notifications have changed upon notices of resolution being, the notification process has not changed. So if folks have opted in for notifications, they'll continue to receive those.
Hi, this is James Wesley with Claims Operations. There was a question regarding whether there's thought at the moment to allowing payers to deny a request because a body part has not been accepted or established, and that is not something that is being considered at this time. If the body part is not accepted or established, you can go ahead and grant without prejudice. Now you can do that at level 1 or level 2, or undertake a medical review and deny it on the basis that it's not medically necessary. There is another question about C8 forms, and presumably that's referring to C8.1Bs and C8.4s, where the carrier advises the provider about whether medical bills are being paid or not, and why they're not being paid or why they're being partially paid. I think we would all love to see some more electronic interface between parties on that, but that is not something that we are looking at this time, at least.
Now, this is Dr. Tachi. There's a question that states regarding medication PARs, if the medication PAR is denied on level 3 review, is there a way to prevent the provider from submitting the name, the same exact denied level 3 as what was denied at level 3 request as a new level 1 request? So basically, if a medication PAR has gone through the entire PAR process as level 3, can the provider be prevented from submitting the same PAR again as a brand new PAR? So the system prevents the provider from submitting an identical while the PAR is being processed. After denied at level 2, the system does not currently stop the provider from submitting an identical PAR. We have published guidance multiple times and in multiple different settings where we've told providers, and this is not limited to medication PARs, this is for any PAR type. And we've told providers that they should not be resubmitting identical PARs for the same patient, same diagnosis, same treatment, or same diagnostic test, that when the PAR has already been denied, without a material, clinically significant change in the patient's condition or function that would justify the new PAR submission. So if there's something new clinically that's happening or functionally that's happening that justifies the resubmission of the same identical PAR, then providers can do that. But if there hasn't been, if they're just resubmitting it for the sake of resubmitting it because they want to ask the same question and there's been no change, we've specifically asked them not to do it. And if you do see a pattern where providers repeatedly do that without a clinically significant change in condition, we would ask you to bring those to our attention. Send the complaint to the medical director's office. It will be forwarded to our provider compliance committee, and we will look into the situation and perhaps contact that provider.
So then there was a question about carriers being aware of approval by apportioned carriers. I think at this point we can only encourage carriers to remain in communication and share information on claims when there is a PAR that they're both responsible for. And then similar to the question Dr. Tachi just answered around level 2 denials, if level 1 is proposing that something be granted in part, but then level 2 ultimately denies it, the level 1 response never goes directly to the provider on its own, and it's not binding on the carrier because it's the level 2 response that's final. So if a provider requests prior authorization and provides the service before it's denied at level 2, the fact that it was denied is still a reason to deny the service, assuming that the service is what was requested and there is a legitimate reason to deny the PAR. There's also a question about how to submit general questions or questions about regulations, and can claims at wcb.ny.gov be used. Claims at wc.ny.gov is no longer a valid email address for submitting inquiries. We do send responses from there, but it's an unmonitored mailbox. The board has a contact page with different phone numbers and email addresses for various other units. So I think we'd encourage you to link there to make those inquiries. And if in doubt, the 1-877 helpline number is always available. And it looks like my response on apportioned claims has generated some additional questions. Just to clarify, apportionment is when there's either 2 insurance carriers on the same claim or more than 2 insurance carriers on the same claim who each have a responsibility for a portion of the payments. Apportionment can also be between claims that relate to the same injury. As far as who is responsible, that generally varies depending on, it's, I think, generally true that the carrier with the higher apportionment percentage is the one who makes payment, but those agreements vary depending upon the claim. So there's not really a universal answer we can give in that regard.
Now, this is Dr. Tachi again. There's a question: how long does a New York denial approval stand? I'm assuming that's refers to the PAR process, and either the carrier's denial or approval or the MDO's denial or approval through the PAR process. There's not a blanket answer to that question, and it will depend on the clinical circumstance, right? If something is approved, if a clinical intervention is approved, it remains approved as long as the individual requires the clinical intervention and there's been no change in their clinical status that would make them either no longer require it or alter their risk profile so that they should no longer have that clinical intervention. If something is denied, then the denial stays in effect unless the patient or their legal representative seek to have it adjudicated, and that decision is reversed. Or again, if there's a clinical status, just like we talked about before, a clinical status change with respect to a resubmission of a PAR, if something's been denied, but the person's had a change in their clinical status that may re-warrant consideration of whatever the intervention was, then a new PAR can be submitted.
All right, we are going to go ahead and wrap up today. I want to thank you again for joining us today. I want to thank everyone from Claims Operations and from MDO for hopping on to answer your questions. As I mentioned, a copy of this presentation as well as a recorded version will be posted on our webpage and our YouTube page. So as soon as that is available, we will email you. If you are not signed up for email updates, please do so. You can go to our website at wcb.ny.gov. Scroll down to the bottom of the homepage and select Get WCB Notifications. You choose the topics you'd like to subscribe to, and we promise not to inundate you with nonsense. It will be stuff that is pertinent to what you're looking for. We also include information on future webinars in those email updates, so you can be on the lookout for those as well. And we do also distribute information via social media, so make sure you are following the board on Facebook, Twitter, Instagram, and YouTube. That YouTube page has dozens upon dozens of previously recorded webinars and other presentations, so we highly recommend you checking that out as well. Also, don't forget to visit the payer-specific page on our website. If you go to wcb.ny.gov, you can select payers at the top of the page. Finally, before you sign off today, you will be directed to take a brief survey. Your answers help us improve our future webinars, so we do appreciate you taking a couple minutes to respond to that. Again, thank you for joining us and enjoy the rest of your afternoon. Thanks, everyone.